All right, great. Well, we'll get started. Welcome, everyone. We are thrilled to have today one of our own, Elise Ruan, who is a clinical informatics fellow at NYP and DBMI. Her research focuses on using interdisciplinary approaches to develop and validate new methods to evaluate health information technology and its associated clinician burden. Dr. Ruan received her bachelor's in brain and cognitive science from MIT and an MD MPH from Tufts University. Medical Center, Albert Einstein School of Medicine, and as a practicing hospitalist here at NYP. Thank you. Welcome, Elise.
Great. Thank you, Sarah. I think I know everyone here, but I'm here to talk with you guys today about burden measurement, specifically about how to evaluate and apply these different approaches to burden. There we go. So I want to start with the definition of clinician burden, because it really kind of frames the way that we can think about burden measurement. So this definition I like because it covers three main areas. So it's defining it as clinician activity that does not serve patient interests, does not improve quality or safety, or regardless of intent is highly inefficient. And so clinician activity, this activity could be physical, it could be cognitive. So physical, like having to fill out a form, having to click on an extra button, or cognitive, like having to double check something, remember something when you go to a different page. And this activity is also considered unnecessary because it doesn't have a positive impact on anything. So obviously some clinician activity does improve outcomes. Sometimes making them double check something does benefit patient safety. But even if the activity may be necessary and positively impact outcomes, it can still be considered burdensome if the process itself is simply inefficient. Hello?
Hello, this is you.
Okay, hi. And so if it's just inefficient, it takes a long time, it's difficult to do. And so I'll specifically be talking about clinician burden in the context of health IT. And the reason for that is that with health IT becoming a larger and more important piece of healthcare delivery, the clinician burden associated with such systems is also on the rise. And so it's also on the rise, and it's also HIT associated burden is a huge contributor to clinician burnout, which obviously not only has negative impacts on health professionals, but it's also associated with worse patient outcomes from satisfaction, experience, quality and safety, and also higher costs for systems, especially with clinicians leaving the field. And there have been numerous interventions and attempts to target burden and burnout, from education and wellness sessions to hiring of ancillary services to IT or now AI-based solutions. But a significant barrier to making progress in this area is the lack of useful methods to meaningfully measure burden. And so let's move on to how do we measure burden? Well, we could ask people, and surveys are the traditional method, but there are many limitations such as respondent selection issues. It's very resource intensive, and it's also not very timely. So what would be ideal is if we could gain insights about the user experience in a health IT system without having to rely on the already overburdened frontline staff. And so if we think back to this definition, one part that specifies it's any activity that's highly inefficient. So can we quantify how inefficient these activities are using non-intrusive secondary electronic health record data sources? And how do we evaluate these potential measures to make sure that we're drawing the appropriate conclusions? So user action logs, also called audit logs, event logs, are emerging as a potential source to track user behavior through an IT system. Some EHRs provide this data in its raw form, as well as aggregated, calculated vendor-derived measures that aim to quantify certain usage patterns. And the question is, how well do these measures capture variation in user behavior and experience in the EHR? And so, as we probably all know, in March/April of 2020, we saw a surge of COVID-19 patients in the New York area, leading to many changes to the healthcare systems, both voluntary and involuntary. One in particular was the widespread implementation of telemedicine in outpatient clinics. So what we did here was we used 11 vendor-derived measures that were based on aggregated user action log data and aimed to see if, one, there was any significant variation in these measures between 3 distinct month-long periods that correlated with pre-pandemic, during/shortly after the surge, and a few months after that. And two, if so, whether we can gain any meaningful insights from these variations. So we chose these 11 measures because they correlated to areas that potentially reflect burden. So it looks at for each user, what's the volume that they're seeing? So how many times are they having to go through a process? These were the measures chosen here were aggregate messages, how many appointments they had per day. The second bucket is what they called efficiency. And these were mostly time-based, looking at how long it was taking people to complete their tasks, how long they were spending in certain activities. And then 2 measures that were basically scores that were calculated. The physician efficiency profile, or the PEP score, basically is as compared to others in your institution, how do you perform in terms of how long it takes you to complete a task. Proficiency score is how good are you at using the different types of tools that are developed to boost efficiency, so like templates and shortcuts. And then the last area is called burnout, but what it's really measuring is time spent working in the EHR outside of what would be considered normal working hours. And the reason they called it this was because it's been shown that spending time in the EHR outside of normal working hours has been associated with increased burnout. So these 3 measures really kind of just try to correlate what you would consider a normal working time. So 7 to 7, only scheduled days, or pajama time, which is 7 to 5:30 on weekdays and any time on the weekends. And so what we discovered was that we were able to see significant differences between the 3 periods. I didn't go too into detail here because the values themselves don't matter as much as just whether or not there was a change significantly in either direction. And so all the arrows that are bolded means there was a significant change. And so compared to the pre-pandemic period in August 2019. So if we look at this, based on this, it looks like maybe volume went down a little bit after the pandemic started. People didn't really change how efficient they were compared to others or how much they used tools, but they were spending less time in the EHR doing tasks. They were faster at completing their work, and they weren't working in the EHR as much after hours. And so all these things, yes. No, so it's just a month. Compared to August 2019, the aggregate messages were significantly lower than August 2019 in May. And then in June or in July, the aggregate messages were significantly. And so the double arrow, sorry, it's not super. The double arrow just means that it was significantly lower. And then 1 arrow means it was still significantly lower, but a little bit. So like we didn't do a comparison between May 2020 and July 2020. It was all compared to prior. But I wanted to show that for a lot of them, it looked like there was like a huge change, and then things kind of trended back towards normal, even just a few months after the surge. Oh, sorry. The question for people on chat from Noemi was what the periods were and what the comparison were for the different, like May 2020 and July 2020. Yes, pre-pandemic. But so basically, from looking at this data, it looks like everything got better with the pandemic. Physician burden must have gone down. And so what's the issue with that conclusion? The big issue is that these measures are both too broad and not broad enough to gain real meaningful insights. It doesn't distinguish between any number of reasons why someone may be spending more time in a note or more time working after hours. It also isn't broad enough to draw conclusions about burnout, because from surveys, we know that burnout is increasing for physicians since the pandemic because of many individual and environmental factors that just can't be captured in use of log data. Another limitation to this data is that the data was aggregated at the user level. So there are user level or user specific differences that play an important part. So previously I mentioned that studies have found that there's an association between EHR work done outside of work hours and burnout, but that may not be the case for all users. And in fact, another part of this study, we examined differences in these measures between based on gender, specialty type, and years since graduation. And one of the differences was that female physicians tend to spend more time in the EHR outside of working hours. And this could be due to any number of reasons, familial obligations, childcare, and this doesn't necessarily mean that they feel more burnt out. The original intent of these measures also was to help organizations identify users who are performing well and efficiently and those who weren't, to try and troubleshoot some sort of training or intervention. So it isn't quite what we were trying to understand about the experience in health IT. We weren't trying to figure out who was good and who was not as good. And the last issue of whether or not these measures are usable is kind of connected to these first 2 points, because based on this, these measures don't give us a great sense of how much burden clinicians are experiencing, how much burnout they may be experiencing, and they don't help guide us in any potential interventions to decrease burden. So, yep. Oh, yeah. Yeah, so these were just attendings. So it was starting, and then yeah, it's just years since they finished residency. And so for that, I think the only thing that we saw significantly differently was their volume, like how many patients they were seeing. Yeah, right. Like, so you don't know what they're doing during that time. You just know the overall time they're spending on this one page or tab. So let's go back to our definition again. This time I want to emphasize clinician activity. So instead of looking at users or trying to capture user-specific or external environmental factors, what if we focus our attention on the activity or process itself that could be burdensome? And so the activity or workflow I want to talk about is the process of ordering, or the computerized provider order entry system. For those who don't know, the CPOE systems are the main way that much of clinical care and communication is done. So medication orders, lab tests, consult requests, nursing communication are all now done through orders. And the data that I want to talk about is another vendor-derived measure that once again uses aggregated log data called orders friction. And the orders friction aims to quantify how many user-initiated actions are needed to complete an order. And it counts basically how many changes, it's made up of order changes and alerts fired. So it counts how many changes were made to an order and how many alerts were triggered and had to be addressed before the order was successfully placed. I'll go into this in a detail in a little bit, but I want to point out that unlike the data used in the last study, this is aggregated by like order type as opposed to by user. But similar to the prior measures, it still needs to be validated and understood in the context of what's really happening clinically in the real world. And so with the help of an operational work group that was focused on reducing inefficient order processes, we developed and proposed a practical approach on how to do exactly that with the orders friction data. And so this is the approach we came up with. I'm only showing it to really highlight the first 2 steps, which is understand the process in detail and understand how the data elements fit into that process contextually. And so going through this really quickly, kind of just for background and for context for everyone, this was with the help of multiple stakeholders, from clinicians to people in lab and pharmacy and the EHR vendor. We mapped out what the basic workflow of placing an order at our institution was, and if and how these activities would be captured in the order data. So it starts off with a user, usually a clinician, goes either to an order set, which is a pre-curated list of orders, or they search the general list of orders. They select the orders they want to place. They make any modifications to the configuration or settings on the order. They try to sign it and may or may not trigger any number of alerts that need to be addressed. And then they go ahead and sign the order. It goes into some information system, either back into the EHR or to an ancillary one, with the goal of reaching someone else on the. And so working with the same group of stakeholders, we were able to determine that the order friction data elements had information on these specific steps of the workflow. So the specialty and type of the person who placed the order, where the order was placed or selected from, what settings it was placed with, how many alerts it triggered. And the last 2 are the most important because these are what make up the order friction score. And so Specifically, I want to focus on order changes. And there was a lot of work that went into understanding how order changes were calculated. And so I'll show you, if you guys can see, these are two examples of the types of orders you can place. One is a lab test, this is a urine drug screen. Another one is a medication, IV ketorolac. And so when the user selects this order, these are what the default settings look like. There are some red exclamation points, or these are hard stops that need to be filled in order for the order to be placed. And then there's some default settings that were already selected, like today, at this time, intravenous versus intramuscular. And so seeing this, the first question is, how is order changes calculated? Is it counting how many clicks? Is it counting the keystrokes? If you select AM draw, is that one order change? If you switch to PM draw, is that another order change? So this was important to figure out, and we determined that it was actually not clicks or keystrokes, but it was just that each order has a set of fields or elements that may or may not be required and may or may not have something pre-populated. Order changes just counts at the time of signing how many of these fields are different. So if I go and click on AM draw and then PM draw and then accept and sign, that's one order change. If I change this from 1705 to 1800, that's one order change. So filling in and changing the same thing. It's just if it's different. And so let's think back to some of the limitations of the prior study and how this differs. Because we focused on a very specific workflow, we're able to really understand the log data measure in a way that we couldn't when we were just looking at overall time in inbox or in notes. Because it's aggregated by process and not by user, there's more of a focus on the activity itself, which could help inform optimization strategies. So that's a little foreshadowing to the last question, is then how are these measures usable? And so I want to take a step back now and put forth this very basic process map. And because everything kind of just boils down to a user engages in a process to reach an outcome. And you can argue whether or not there's a decision involved. People might say it's due to regulation or hospital policy that they have to do this. But at the very least, the user decides in the moment to engage in a process. And so some examples of processes or workflows that could fit into this: physician cares for a panel of patients in an outpatient clinic, physician writes a note for a clinic visit. And these two correlate to the kind of workflows we were looking at in our first study. The third one, inpatient provider orders a urine test for an admitted patient. And this one correlates to the kind of workflows we were studying with the order friction data. So far, our approach is we have this process, how inefficient or how difficult is it? And so thinking back to our order friction measure, specifically the order changes, let's see how that could help us evaluate and reduce friction of an ordering process. And so one strategy to reduce friction or inefficiencies in a process is the modification and addition of defaults that promote workflow alignment. So as suggested by this article that came out of the American Medical Association, but the first step is to understand what is the current state? What are people changing in an order? And so what if there was a way using data to know what these changes were so that we could potentially change them so that instead of all these fields showing up on the default settings of these orders, the default order settings would look more like this. So in addition to data, data, there was also a data set that identified order processes for users making many of the same changes, and it included information about the order's default settings and what the users were changing them to at the time of signing. So for example, if you look at the urine drug screen test on the left, it has only one required field that was blank, and that was frequency. And we were able to find that the majority of users are changing this frequency once. And so this is, once again, with the work group stakeholders, and we basically went through this process cycle where we engaged in that first step of identification through the data to identify potential optimization opportunities. And in this case, it's maybe changing the frequency of the urine test to once. It brings us to our next step, which is design and evaluation, which is, is this change feasible, technically feasible to do? Does it make clinical sense? And is there a safety concern? And so for our example, we determined that one, yeah, you could make this change relatively easily. And two, it made clinical sense because urine drug screens are very rarely ordered multiple times. And it's also very rarely ordered as a timed test because patients don't really determine when they give you that sample. And so we went ahead and implemented that change. And then we needed to collect feedback and monitor how that change impacted users. So how would we collect feedback then? Well, once again, you could go and ask the frontline users how they feel about this change. Did they notice anything? Or you could actually use the measures from the order friction data to get some of this information. And so this example, we use the measure of changes per order, which is just total number of changes that were made over total number of orders that were signed. So that for 22 lab tests where we defaulted the only required fields to a frequency of once, and these were all urine, stool, or swab tests. So kind of using the same logic and rationale for urine applying to just all of these kinds of tests. We showed that users went from having to make 1 to 2 changes per order to the majority of orders being placed without the user having to make any changes, probably saving them at least 2 clicks per order placed. And so now we've shown that this measure is not only contextualized, but it's applicable and usable in a real world setting to support burden reduction efforts. Yep. Mm-hmm. Yeah. So I mean, that discussion is very medication. What happened? Something that was not. Sorry, I should say that the question. Oh, audio is no longer audible. Okay, now it's back. Okay, let us know if it cuts out again. There's a question, yeah. Yeah, so even chat, if you don't face the laptop, the audio will cut out. But I'm facing the laptop. Okay. Yeah, so that's the thing, is that we discovered that blank to filled is the same thing as change from one to the other. So that's why actually we focus so many of ours in filling the blank ones, because at the very least, all the people who are using the most common setting don't have to make that change, versus people who are maybe using the second or third most common, they had to make the change anyways. And so overall, we're able to make it easier. But that was something that makes it easier. Where is the mic? Okay. Okay, I will face this. Okay. All right. And so going back to this very basic process map, we're going to switch gears a little bit. And so far, we've been assuming that the process that the user is trying to complete is what we want the health IT system to make easier through better workflow alignment and reduced inefficiency. But what if the user is engaging in practices or behavior that are not preferred for quality, safety, or resource constraint reasons? And we actually want them to guide them towards a different process with better outcomes. So if we think back to our use of defaults and to make processes easier, another thought is if we make one process easier and another one more difficult, can we get users to make a different decision? Can decreasing clinician activity or friction work as a form of clinical decision support? And so I mentioned before in our step of design and evaluation, where we considered what impact changing a order's default settings would have on user behavior. Here are some examples of desired or undesired behaviors that we try to encourage or discourage. So the first one is the desirable behavior of grouping non-urgent lab collection times together. The motivation behind that is to optimize phlebotomy's workflow and also minimize patient discomfort so they don't have to get multiple blood draws. The intervention that we did here was that we defaulted collection time for all for non-urgent labs to a routine morning draw, so they would get all that collected in the morning. The other behavior that we wanted to encourage was starting opioid medications at the lowest dose. The motivation here was because there are adverse effects with these types of medications, and they're worse when they're higher dose. The intervention here was that we defaulted doses of some opioid medications to the lowest dose. So people are still able to order a non-urgent lab at a different time or order a opioid medication at a different dose, but they would have to do an extra step. And then the last behavior actually wasn't from the order friction work, it's from a prior project that we worked on, which was to discourage ordering of statin things, okay, for patients who are on a statin medication that were not having any signs of statin-related muscle pains. And the motivation behind here is that guidelines and recommendations pretty much suggest very little use for a elevated CK in a patient that's on a statin that's not having any active muscle symptoms. And ordering these tests causes stress on the patient and also waste resources. So the intervention we did here, we just took that creatinine kinase order off of a commonly used order setting panel that outpatient cardiologists were using. And all three of these interventions were able to show a significant increase in the behavior that we were trying to target. And so kind of going to speak with stakeholders, we look at the usage log data, we implement a modification that makes process B easier and by default process A more difficult. But what if we see, even when we make the process more burdensome, users are still going through process A? So the first potential scenario is that we misunderstood the optimal clinical workflow and that users really do want to go through process A, and all we did was make it more difficult unnecessarily. So an example from the order switching work was that we saw this with one of our interventions where we defaulted the most common dose for medications. So if you look at this graph, it looks like all the medications saw a decrease in per order except for one, and that is aspirin. Left, where we changed the default to 81 milligrams. And after we made that change, we actually got feedback in the form of a ticket that was submitted by users saying that they were having trouble with this order. They couldn't find the right order. They wanted 325 milligrams. Is it still this order? Is it now the chewable one or the crushable one? And so we actually ended up changing this back because our data was able to confirm that people were now making as much, if not more, changes to it, or that it didn't really actually benefit them the way we wanted it to. But scenario two is, what if process B is what we really want them to do, but somehow adding this additional friction or activity wasn't effective at impacting decisions? So either users don't understand the reasoning behind it, they're not engaging with it, it's just not effective. And what do I mean by that? So if we go back to our definition again, the part that we've glossed over so far in our approach is the connection to impact. If we take alerts, for example, initially it sounds like a great idea. The user is trying to follow a flow or path, and the alert stops them to ask them to think again, or if they want to engage in another process. But we know now about the many cases of too many and poorly designed alerts, where it's just added inefficiency and difficulty that users just gloss over, and it doesn't impact their decisions or patient outcomes. So where does this fit into burden measurement? Basically, it may not be enough to just measure how inefficient a process is. We need to tie it to effectiveness and outcomes. If we choose to use friction or burden as clinical decision support, we need to measure how worth it is, this additional clinician activity. And so expanding on our basic process map, this tries to incorporate some of the decision points that users have when interacting with activities that aim to impact and support clinical decision-making. I separated the outcomes at the end, the process the user is engaging with, the health IT, while the outcomes can be patient level, system level, can happen whether or not the user engages in either process of all these other factors. So an example will help here. The example I'll use is central line associated bloodstream infections. And so sometimes in the hospital, a patient will need a catheter placed in a large vein that feeds right into the heart. There are many reasons why they may need this for certain medications, procedures, types of measurements. Usually these are sicker patients in the hospital. But the problem is it gets infected. It has much more serious consequences because it's so close to the heart and the infection goes right into the bloodstream. And so in these patients, this has implications for mortality, length of stay, which is not good for the patient or the hospital. And so the idea is that you want to minimize how much time a central line is in and to remove it as soon as it's not necessary. Studies show that reducing the number of unnecessary central line days will reduce the rate of infection, which kind of feeds into the CDC's recommendation of daily assessments of central line necessity to remove it the moment it's not needed. And so going back to our process flow, so if we want to evaluate some type of activity that is implemented with the goal of having fewer patients with bloodstream infections, we can start by working backwards, where the outcomes that are motivating this activity is patient level and whether or not they got a CLABSI or bloodstream infection. And the two processes that the user can take is they can either do the daily assessment or not do it. And so for our first example of a type of activity that may have been imposed with the goal of reducing CLABSIs in mind is a alert. So it fires for every patient that has a central line. It asks the provider, do you want to remove it or document why it's needed? Or do you want to just ignore and dismiss the alert? Starting from the beginning, so either the user was going to do the assessment or they weren't, or they forgot and weren't planning on it, in which case they would be prompted by this alert that would hopefully push them into another decision about whether or not they want to do it. And ultimately, the patients they're caring for either get an infection or they don't get an infection. So how would we check the burden of adding this alert? Well, we can try to quantify just how much extra activity this was. So this could be how many clicks, how much time. A good option for alerts is just number of alerts, because you know that every time an alert fires, it requires some maybe cognitive, either like in the form of an interruption, or physical, where the user has to click on something type of activities. And so many burden measurements would focus just on this. But because we know that this activity was imposed for a reason, such as reducing CLABSIs, shouldn't we also look at how effective or impactful this activity is? And so to do that, we want to look at ways to measure what happens downstream. So the first step, which is sometimes captured, is engagement. So how effective is the activity at even getting the users to engage with this decision point? In this case, we have alerts data, which tells us what users do with the alert when they get it. How many of these alerts were dismissed? How many times did the user clicked on something that we wanted them to, like an order or a flow sheet link? Next, we want to look at whether or not they engage with the activity, just if they made the right decision to begin with. How did adding this alert change how many patients were getting assessed versus how many were not? So what was the proportion of desired behavior or action? Examples of this could be the proportion of patients that had daily assessments done for all the days that they had a central line, or you could look at patient level, where it's of all the days that they had a central line, what proportion of days did they have an assessment done? And then finally, you can look at the outcome. So what is the rate of the desirable or undesirable outcome? And our example would be something like the incidence of a central line associated bloodstream infection. So now we have all these areas of measurement, and you can potentially get a sense of how effective the extra activity is at impacting, one, the action and behavior of users, and two, the outcome of interest by comparing the volume of burden with the rate of desired behaviors or outcomes. And you can almost interpret it like a number needed to treat, where the intervention is that additional clinician activity and the outcome is the right behavior or outcome. And so this is relevant for comparing interventions with varying levels of required activity, with possibly varying levels of effectiveness. So maybe two types of alerts that are trying to accomplish the same thing. Or we could do this for another type of health IT activity, like changing orders. And so going back to our example of the desired behavior of having users start opioid medications at the lowest dose, we can see how implementing the change of setting the default dose as the lowest adds some extra activity for users who want to order the higher dose. And this would be captured as order changes for the volume. But the goal would be to increase the behavior of ordering lower dose opioids and reduce adverse drug events related to higher dose opioids. So note here that the engagement measure is trickier because, unlike alerts, we don't have users performing any actions that the EHR could indicate more or less engagement. Potential strategies here could be, eye tracking, maybe see if people are looking at the dose field still. But either way, it doesn't keep us from being able to correlate the amount of activity imposed and the desired impacts. And the last example is from the undesired behavior of ordering creatinine kinase of patients without any symptoms of statin-related muscle pain. So unlike the other two, the motivation here also extends to the health system. So unnecessary testing is harmful not only to the patient, but also wasteful of resources. So here I included it because the final outcome could also be the cost of unnecessary creatinine kinase tests. And this type of measurement can help motivate health systems maybe in supporting these types of optimizations. So some key takeaways. An interdisciplinary approach is incredibly important because it's all about context. And you can see how going through the process of ordering and seeing how the order settings look and how their changes translated to what people are seeing and experiencing in their workflow was an integral part of this process. You also need to understand what's happening to be able to, one, identify potential opportunities for optimization, and two, track and monitor the impact of any changes you do make. Measures should ideally be developed with a clear and specific purpose. And sometimes with these data sources, going smaller is better than trying to capture everything all at once, and focusing on specific activities and processes make it easier to really be able to interpret what these measurements or changes in measurements mean clinically. And the last is many of the perceived burdensome activities were implemented for a reason. And it's important to keep that reason in mind as we're measuring and evaluating burden. It would be like studying overall cost instead of considering cost effectiveness. So sure, it would be great to just cut costs, but it would be better to cut costs and be effective so that we don't cut things that are necessary. And we may want to even spend capital on things that are necessary. People are also, from a perceived burden perspective, much more forgiving towards things like cost and burden if they see a demonstrated value. And so my next steps are to expand on the methods and approach of using log data to optimize the process through workflow alignment and to apply it to facilitating EHR personalization. So EHR personalization is a term to describe the use of different EHR tools and strategies to boost efficiency, such as note templates, order sets, customization of your layout and shortcuts. And it's been associated with increased user satisfaction with EHRs and decreased burnout. But even so, surveys show that up to 2/3 of providers report little to no personalization of their EHR, and a big portion of that is the burdensome kind of process of knowing what changes to make and being aware what their usage patterns are. So if we are able to use the usage log data to understand the ordering behavior in the entire health system, which we were limited by because it had to be kind of consistent with the workflows across all specialties, if we can be more specific in the workflows, then the changes we make can also be more specific. And the other area of interest that you may have gleaned from the last section is to expand on this idea of burden or activity effectiveness. In this initial framework, important types of measures have been identified. And so the goal is to figure out how we're able to use secondary EHR data sources to answer these questions. So there's potential for using log data that measures time spent in specific activities or how much switching there is between activities. But the importance here is how the measure of activity volume is created, and that it will have to be specific to a workflow, which is what I demonstrated with my 3 examples, how each of the measures were quite different. I want to thank all of my project collaborators, my mentors, advisors, both before and especially here during my time in fellowship, as well as to all of you. I really appreciate the opportunity and I'm happy to take questions. The one for the central line, the activity was an alert, but Mhm. 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 So it depends on the alert. And so I think that's what there's been lots of studies that show that alerts are primarily ignored, doesn't change outcomes. But one of the big limitations is that it very much depends on the alert itself. And so this kind of provides a way to then evaluate alerts, because you could have two different alerts trying to serve this very same purpose of getting people to do that daily assessment. And it can vary in terms of what language is shown, do they give resources? There have been some studies about alerts that they can be more effective if in the same alert, providers can click on like the guideline or the background that's influencing this decision support, as opposed to just saying, watch out for this. Because there's, as people feel like alerts are not well designed, they don't apply to this situation, people will be more likely to ignore it. Because the idea is, how do you design an alert, if alert is the way we want to go, that get people to even engage with the information that we're trying to get them to engage with. And so the alert, I use it as an example because it's very measurable and it's very common. But the reason I kind of came up with this framework to begin with was because of this other intervention that's gone on called the quality checklist. And the idea is that we take these alerts and we put them on a checklist, these items. And so people are not being interrupted. They can just go to the checklist when in their workflow and in their kind of cognitive processing, they're ready to deal with these questions. And the question is the amount of alerts that we're firing and now the amount of extra work that's in this checklist. If outcomes don't change at all, if you can prove that at least the activity has gone down, then it could be a worthwhile change. And so it's not about alerts specifically, but I think there have not been enough studies that kind of do this assessment of alerts. They just look at like, oh, alerts fired this much, or, oh, like people got this number of infections afterwards, but they don't look at if the alert actually got people to change their behavior from like engagement to action to what application. Mm-hmm. 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 Oh, yes. So the question is, would it be beneficial for providers to know that an alert leads to improved outcomes, and how would you communicate that to them? And so that is actually an area that a lot of focus has been, because one of the issues with the checklist is that we're having trouble getting people to use it. And one of the strategies is to, well, we need to prove then using this checklist impacts outcomes. And so I think there are very few alerts out there where in the alert, it tells you that if you like places with this alert have better outcomes. And I think part of it is because there are not that many studies that have actually studied that one for this specific alert. So you can't just say all alert, like any alert improves outcomes. You have to say this specific alert in this current format with this current like decision tree improves outcomes. And there are not that many studies that have done that. And so not many alerts get to say that per se. They might be able to point to this guide, like this alert is based on this guideline, which has shown that it's improved outcomes, but it's a few steps removed. And then also, like, if regardless of how well designed the alert is or what it's covering, if the engagement is really low, then it doesn't matter what the alert looks like. So the way we measure engagement is that for some alerts, people can just X right out of it, or they can say not primary provider, which a lot of times we can see that they were the primary provider, and it's a quick way to get it out of their way because they're trying to do something. And so the question is, an alert can be having very little impact because it's a poorly designed alert, because it doesn't, align with clinical care, or it's a poorly designed alert because it's not engaging with people. And so there are, like, from an operational standpoint, there are like quality, departments for each hospital where their role is to communicate with frontline staff what the purpose for these different interventions are, to get them to use it, to understand the benefits. And so I was asked for some of the quality checklist items to hand over like a little bit of data that could show that maybe going to be less venous thromboembolism if you do this checklist, so that they could kind of use it as like propaganda to get people to use it. But it is, I think then that's kind of more like an operational question, like how do you get people to listen to it? But you can also potentially design an intervention where they don't need the education. The intervention just kind of fits into their workflow and encourages them to do the right thing. And like an example for here might be then if we just make it so that the default is the lowest, you might see people, even though they may or may not know that the lowest dose is the best thing to start with, they may just start doing it because it fits so well into their work. Yeah, so the question is, what other kinds of tools or activities could fit into this framework? Maybe things that are more complex, like predictive models. And yeah, I think the reason that I created this was because it should fit into any sort of intervention that aims to change what the user was going to do without the tool. And so I think people always, with the thing like, informatics is just the person plus the machine is better than the person. So the idea is that the person was going to do something if they didn't have this predictive tool, if they didn't have this information, if they didn't have this alert. And now you add that extra step or tool in because you want them to do something different. Or you, right, like even if it's you want them to double check, you want them to do something different. And so I think people come up with like really great types of tools, really accurate, really generalizable, all these things, but then you can't get someone to engage with it. And so I think before you try and do the assessment of, oh, like, did it impact outcomes? Did it impact anything? You first have to go through this framework and see, did it even impact their willingness to engage with a different decision? And why that may or may not be. And so like, if we think of potential tools that are kind of put out there, is that the generative AI, like inbox messaging. So you can count how much extra work or how much work it was to answer inbox messages. That will be your, volume of activity. And you can do it before and after. So before, to answer an inbox, they had to do all these things. You could do time, you could do clicks, typing, all that. And then after the generative AI, you measure how much activity it took to do that. And then if you're trying to change specifically, like you want them to now document smoking status better, and generative AI can maybe help that. Then you can look at how many patients have the smoking status documented. And then you can look at, well, I guess there's not any outcome beyond that, maybe reimbursement, final outcome for a system-wide outcome. But yeah, the idea is that when you're implementing a tool, you have to think about where it fits in and how you can tell that it worked, as opposed to just kind of waiting for people to complain or waiting for something else to come along and replace it. Yes. Mm-hmm. Okay, so the question is, how does this differ from two main bodies of work? One is kind of just related to general web stuff, and then the other one is specifically with the EHR. And so I think the difference, or in my opinion, the difference here is that I think there's two kind of separate thoughts about clinical decision support. One is that it's too burdensome, it takes away autonomy, it's not it's a huge negative on the EHR. And the other one is that care is way better with EHRs, and users, need the support. They make lots of mistakes, and how do we kind of improve that? And so I feel like the kind of work that's being done in both silos work somewhat independently. Like, people create tools or algorithms that they think will really impact care positively, and then they also do interventions. Yeah. 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 Yeah, I guess I'm not sure if it's like, I don't know if I can pinpoint the kind of like significant difference. I guess the way I always thought about it was that this is just very applied, in that like you're developing burden measures not to just understand the measures, you're developing these measures for the purpose of using it to implement something or using it to improve something. And so that when you're creating these measures, you already have like an application for it, as opposed to just trying to understand better the kind of like how these things interact. I think that's kind of because I came to this framework through just actually trying to develop a measure to apply something. And that we have a lot of measures that were just not usable because they were developed like before we had an intervention or before we had in mind. And so I think that's kind of maybe how my approach differs, is just kind of the motivation behind it. The web. Yeah, I guess like it almost like take I think inspiration from like other industries who are much better at kind of automating. I think the difference, so like the web, I think those kinds of things are motivated both by trying to steer you in a certain direction, but also to make it easier for you to do certain things. I think the motivation behind optimizing the EHR is probably not as, I don't want to say paternalistic, where they're like trying to get you to do something against your will or trying to get you to do something different than you would want to do on your own. So I think there's a component of like the EHR should be supporting you in what you're doing, and they shouldn't have like an ulterior motivation. Does that make sense? Yeah. 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 Yeah, I think the difference is that there are two like motivations. Like the first half I spoke to more just make whatever they're doing easier. Like whatever they're doing is effective. And then the second school of thought is, well, we don't want them to do everything that they're already doing. And so how do we change that? And so I think like if you think about like the EHR compared to others, like there's balance. I think we talked about like standardization versus like autonomy. And so like how much standardization of care should the EHR technology try to support, and how much kind of personalized individual like clinician autonomy. And I think compared to like the web, there's probably hopefully like leaning more towards the clinician autonomy, but I also understand like in large academic centers that it may skew more towards like standardization, like everyone should be getting the same care. But if you go out to like a clinic in like a more rural area, then the IT system should still kind of support them as well. Yeah, I think that clock's fast. Mm-hmm. Mhm. Yeah, no, I definitely agree. And like one of the motivations behind this checklist was we had all these alerts that we knew from the engagement numbers and we knew from the action numbers that were not impacting care. And the idea is, can you create something that's better? I don't know if this framework would be enough to necessarily discover those opportunities. I think this framework is important to know that your activity fits like here. It fits before like a second decision point or after a decision point, to try and target what the kind of characteristics are needed to make it more impactful. So one of the issues with alerts is it interrupts you. You're less likely to get to that point because you find where in the workflow that people engage with a decision support. And so actually, I think another opportunity for users log data is that if we're able to see that people place the order central line or they document the necessity in the same point of the workflow or at the same time, then potentially you could design an alert or whatever activity to fire at that time, as opposed to having it fire first thing in the morning before they've seen the patient or something like that. And so I think that could be like a potential strategy. But yeah, I think this also was helpful because very quickly you can look at this, you can look at what activity or intervention they have currently to achieve these outcomes, and you can tell very quickly that those things aren't working. And so one example is that expiring medications is a alert that is universally an issue across NYP. It fires whenever there's a medication that's going to expire in 48 hours. No one looks at it. It's a safety issue. Medications expire all the time, and the pharmacy, the pharmacy information, like they're all very struggling with this. And then on the user side, they're really struggling with it because they're getting alerts several times a day every time a medication enters that 48-hour period. And so the intervention that we've been discussing is that, well, why don't we then lower the amount of activity that is coming from these alerts, if it was an alert? And the discussion we've had is that we know it's 48 hours. And so we have the alert, we have at 6 a.m. all the medications that are expiring will trigger an alert. If you address all those medications and other medications expire throughout the day, it doesn't interrupt you. It doesn't cause an alert. You don't get alerted about it until 6 a.m. the next day. And you still have 24 hours. And so like these kind of like small tweaks are kind of driven by can we lower the activity and maintain the same amount of outcomes, or can we increase the activity by a small amount and improve the outcomes? And so I think that could maybe be helpful in when you're creating new ideas to have that kind of measurement framework in mind, so that you can think about things like, even if I'm adding some extra, it may be worth it, or let's not change any, let's not worry about the outcomes and just try to bring down the activity. Okay, thank you.